Thank you very much. I'm pleased to be here to talk about a favorite topic of mine. Let's see, nothing seems to be coming up. Okay, so there's my disclosure, which has to do with donation of catheters to our ongoing research study, but nothing to me. Great. All right, so we'll be talking about myocardial infarction with non-obstructive coronary artery disease and the management strategies. So we have to start by asking, what do we even mean when we say MINOCA? It's been recognized for as long as people have done acute angiography in myocardial infarction that some patients have no significantly blocked artery on that acute angiogram. And the significance level is typically set at a threshold of 50% stenosis, but this is somewhat arbitrary, and you will see papers using 30% or 70% on occasion. This field took a leap forward when myocardial infarction with non-obstructive coronary disease was recognized in the universal definition of MI as causing 5 to 20% of spontaneous MI cases. And it's also been very helpful for the group to settle on a common terminology, so we're now calling this MINOCA. MINOCA has certain diagnostic criteria laid out in the position paper that you heard about, and the first thing is that this is a myocardial infarction, so it has to meet the universal definition of MI, which has to do with positive cardiac biomarkers and then corroborative clinical evidence, like symptoms or EKG changes or new wall motion abnormalities. But you see nothing here about having to have obstructive coronary disease on the angiogram. And so the MINOCA definition also includes that there is no obstructive coronary disease. This includes people with truly normal-looking coronary angiograms and also people who have some atherosclerosis, but not a 50% stenosis. And there has to be clinically overt specific cause for the acute presentation, and this gets to what MINOCA is not. So MINOCA is not a PE, where you also have chest pain and a troponin elevation, but you have another reason for it. It's not a troponin of 0.1 in a patient with CKD that's flat. You require a rise and fall in the universal definition of MI. It's not somebody with critical AS who has syncope and has a positive troponin. That's critical AS. That's not an MI. So here are the criteria for MINOCA. Are there any guidelines for management? Well, the ACC-AHA guidelines are silent on MINOCA. That's likely to change soon. The ESC guidelines indicate dual antiplatelet therapy and statin for everyone. And then we have this ESC working group position paper on diagnosis and management. How common is this problem? Well, MINOCA is present in about 10% of women with STEMI or non-STEMI who go to angiography, and in a somewhat smaller proportion of men. It's always a more common problem in women. About half of MINOCA patients are female, as opposed to about a quarter of typical MI patients with obstructive disease. When we look at the population with unstable angina, it's far more likely to find non-obstructive coronary disease, but without that troponin, it's harder to be 100% sure that everything is really coming from the heart. Using the AHA statistics and these ranges of prevalence, we estimate that there are somewhere between 54,000 and 187,000 cases of MINOCA per year in the United States. And the clinical correlates are female sex, younger age, and African race. Now, what's the prognosis? I'm not signing up to have MINOCA tomorrow because the 12-month mortality is up to 5%. The prognosis is better than in MI with obstructive coronary artery disease, but it is not great. How are we treating this now? Well, here's some evidence from the ACTION registry, a very large registry of MI, and it shows that we're using the typical secondary prevention medications, but less often, especially when it comes to a second antiplatelet agent. Now, is this the right amount or the wrong amount? How should we be treating MINOCA? So this is the first audience response question. There are going to be 3. So please enter your opinion on how we should be treating MINOCA. Should we be using dual antiplatelet therapy and statin for everyone? That's the ESC guideline. Should we be using dual antiplatelet therapy, statin, and calcium channel blocker for everybody? Do we want to put vasospasm in there and treat that? Should we be using aspirin alone? Or should we be finding an underlying cause and treating according to that cause? And you'll notice I don't have in here, tell the patient that she's fine and nothing happened, because if anybody answers that, I will have a heart attack on the podium. So please answer now. Oh, nice. All right, so we have a range of answers. Nobody said aspirin alone. This makes me happy. But I see a lot of people are saying dual antiplatelet therapy and statin, so that's a very interesting answer. You know, we are faced with these patients. They come to us and they say, all right, you told me I had this thing. You told me it's not good to have. What do you do with me now? And there is incomplete understanding of what to do, and it's really because we don't always know the mechanism, especially without doing additional testing. So we recommend in this working group paper that you should find an underlying diagnosis and treat that, and I'll try and convince you that this is the way to go. So we have a range of underlying causes, and they are plaque rupture and plaque erosion, seen here in representative OCT images, coronary artery spasm, dissection, thromboembolism, Takotsubo syndrome, and sometimes it's not an MI at all, it's in fact myocarditis, which we all know well can mimic MI. So let's start with plaque rupture. Not every plaque rupture is going to be shown on an angiogram, and this schematic shows us why. So we have a plaque here, it has a necrotic core, it has inflammatory cells, smooth muscle cells. This is not an obstructing plaque. And if the shoulder of this plaque ruptures and we get a thrombus that looks like this, we're going to see an obstructive appearance on an angiogram. But if the thrombus looks like that, you can imagine that this luminogram is going to look just fine. So that's one thing that we think that perhaps there was transient complete thrombosis and there's spontaneous thrombolysis. Or maybe the thrombi that are formed are just smaller in these patients and they're embolizing and causing infarction that way. And that's why even though there's a plaque rupture, the angiogram is going to look non-obstructive. How commonly does this happen? Well, this has been studied in 2 single-center studies, one that we did at NYU and Bellevue Hospital with 50 women. They had intravascular ultrasound of 2 vessels, and we found that 38% of the women had a ruptured plaque. There was a French study including 68 men and women. They also did IVUS. They did 1 vessel. They found a prevalence of 37%, nearly identical, of ruptured plaque. It was not possible to pick out who was going to have a plaque rupture based on their clinical characteristics. The only thing that was helpful is that the patients who had a plaque rupture or ulceration had some evidence of atherosclerosis on the angiogram. So these were not perfectly smooth vessels, but they could have just luminal irregularities. For comparison, plaque rupture is present in about half of cases of STEMI based on OCT early in the study Octavia. But plaque rupture is present in only 4% of patients who are in the cath lab solely for research and have IVUS. There is also no plaque rupture in 2 studies of intravascular ultrasound in stable non-obstructive coronary disease. So the Minoka patients look a lot more like MI with obstructive coronary disease when thinking about the prevalence of plaque rupture and less like the stable patients. Another important finding from this study is that the area where there may have been a ruptured plaque, and you see that one here, the arrow's not coming up for me, but in the intravascular ultrasound images on the right, you can see there's a small plaque, and there's clearly a piece of that plaque that has peeled back. That's a ruptured plaque. But in the angiogram on the left, the white arrow marks the spot where those IVUS images were taken, and I don't think that any of us would have looked at that spot and said this is the place where there's a plaque rupture. And we learned that about half of the plaque ruptures were in a location that appeared normal on an angiogram. The vessel might not have been perfectly normal, but that spot looked normal. So we can't really use the angiogram to guide us. If the thrombus is not occlusive, what's causing myonecrosis in these patients? Well, we spoke earlier about the idea that there may be transient complete closure of the vessel from thrombosis with spontaneous thrombolysis. Although we didn't observe any thrombi on IVUS, IVUS is fairly insensitive for thrombi for our series. Or maybe there's superimposed spasm. Finding out the mechanism, MRI is very helpful in this regard. So we saw 2 patterns in our study, and the top one shows us a large area of myocardial edema, in this case in the LAD coronary territory. And this shows us the area at risk, and this was in a proximal LAD plaque rupture patient. So that correlates very nicely, and we think that that problem was really at the site of the rupture, causing a large area to be at risk. But we also saw the panel on the bottom, that kind of a pattern where you see a small, well-defined infarction that almost looks like it was caused by an embolism, as if there were one branch that were occluded. And this is also in somebody with a plaque rupture. And we think that this is from embolization of atherothrombotic debris, although it's still possible that there was also superimposed spasm. Plaque erosion is another type of plaque disruption that has a different underlying morphology, with more smooth muscle and proteoglycans, no necrotic core, and in this case, it's denuded endothelium that leads to thrombosis. This is not seen on IVUS, and so it hasn't been reported in those 2 series, but it is a common cause of MI due to obstructive coronary disease in OCT studies, responsible for about a quarter of cases. This is also more common in young women who die suddenly and are taken to autopsy, and that's of interest when we think about Minoka because young women are a target demographic for that problem. If we don't do intracoronary imaging, there are a few things that we might miss as well. We might miss coronary dissection, which can be angiographically evident and often causes more than 50% stenosis, but sometimes, as in this example, there is a non-obstructive appearance, and you need intravascular imaging to show the dissection. This typically occurs in the absence of coronary artery atherosclerosis and in the absence of atherosclerotic risk factors, and the treatment here is antiplatelet, but probably no statin based on the Mayo Clinic series. Now, as an alternate diagnosis, or perhaps a coexisting diagnosis, we have coronary artery spasm. This can occur either with or without atherosclerosis. It's likely that thrombosis plays some role here, and it can happen with or without antecedent vasospastic angina. This is a difficult diagnosis to make because spontaneous spasm may occur at cath, and that might be helpful, but it doesn't cement the diagnosis, and certainly catheter-induced spasm is something that we recognize. It's important to use nitrates during the diagnostic cath to try and bring out the likelihood of this diagnosis, but provocative testing is typically not done in the acute setting because of the risk from inducing spasm. So most people will do this, if they do it, 2 to 6 weeks later, at which point about a third of patients may have inducible spasm. When it's present, it's thought that it might be the underlying cause of the original event, but it might not be either. The clinical clues are probably ST elevation during a symptom bout, an infarction or a well-defined area of edema on a cardiac MRI. But again, if you have that, it could still be another vascular cause, and you'll be left wondering if it could have been a plaque rupture instead. Now, the treatment of spasm is calcium channel blockers and nitrates, and this is very different from the dual antiplatelet therapy and statin that we'd probably use if we know there's a ruptured plaque. So it would be nice to make this diagnosis, and we may be left wanting to give a lot of drugs because we're not sure. Myocarditis is a very nice diagnosis to make. It's typically made by CMR. It's more common among men. You'll see that there's a huge range of likelihood of diagnosing myocarditis by MRI in Minoka patients, and this probably has to do with how many men are in the series because there is so much variation. The treatment of this is no antiplatelet, no statin. It's really conservative management and management of the LV function. So this is an important diagnosis, again, very different treatment. Then there's Takotsubo syndrome, still some debate about what is causing this, but it is a transient left ventricular dysfunction syndrome with non-obstructive coronary disease. It's sometimes, but not always, triggered by stress, and it can't be diagnosed with certainty in the acute setting based on our current criteria. You really need to document recovery. It's important to realize that apical infarction on a cardiac MR can occur in people who have a Takotsubo wall motion type pattern, and we're showing a poster on this tomorrow. But if there's an apical infarction, we don't call it Takotsubo. The treatment of this is probably an ACE inhibitor, and beyond that, we're not sure. Microvascular disease is often placed on the list of things that might cause Minoka, but I would argue that it probably doesn't belong there. There is not so much overlap between those microvascular angina stable patients and the Minoka patients. And you have to think about how would microvascular disease really cause an MI? How would demand get so high that it would exceed supply in this kind of a problem? Now, there's, of course, spasm, which is on a continuum with endothelial dysfunction, and spasm is certainly a cause of Minoka. We tried to investigate in our NYU series the likelihood that microvascular disease is a component of this by doing stress cardiac MRI, and what we mostly learned is this is not the right test in this time period, because anybody who had an area of myocardial edema was likely to have a perfusion defect, and we think that it was that compression of the microvasculature from the edema that was causing it. So it's a great test for the stable patient, probably not a great test right after an MI for Minoka diagnosis. So now I'll try and take you on a step-by-step look of how we could go about making the diagnosis in a patient we've determined has Minoka. So step one is go back to the angiogram and look for something you may have missed. Look for abrupt ends of vessels, including branches when you're thinking about thromboembolism, and look for dissection. And there are a couple of representative cases I think may be instructive in this regard. So here's a 55-year-old woman who is visiting New York from Scotland. She has no prior medical history, no coronary disease risk factors. She has first-time typical chest pain. The onset was at rest. It lasted an hour, and her troponin peaked at 10.4. She had subtle ST elevation, but it was only in V2. It was dynamic, though. I haven't put in so many movies to try and save time, but this patient has, I hope you can see, an embolism to a septal. And that may not project beautifully here, but it really looked like an ovoid thing in the middle of that septal. And we thought this was most likely to be thromboembolism. From where, we don't know. We didn't do intracoronary imaging in this case. So it could have embolized from a more proximal plaque rupture. It could have, in theory, been in situ plaque disruption in that septal. But we think this was most likely a thromboembolism. And we'd have to look carefully at that angiogram to make sure we're looking at every branch to find it. Here's a different case, a 50-year-old woman who is a traveling activist musician. She has had a very stressful year. She has no coronary disease risk factors. Her chest pain started in June after a breakup. Then it recurred while she was carrying her luggage on a trip. She had ST elevation in the anterior leads and a peak troponin of 29. So she was taken urgently for cardiac cath, and she was told, you know what, you have a variant of your LAD. You have 2 branches to your LAD, and the main artery doesn't really go to the apex, so you have no bad blockage. They did give her dual antiplatelet therapy and a statin. I guess they couldn't ignore the troponin of 29. But they gave her Xanax, and they told her, what we really think is this is probably in your mind. You were just really stressed out. But all my patients are crazy. So she had more chest pain, though, and she came for a second opinion. And the first thing we did is go back to that angiogram. And you can see that, yes, the LAD doesn't go all the way to the apex, but it gets thinner and then thicker and then thinner and then thicker again. This is a dissection. And I didn't show you all the images, but I assure you nothing else was going to the apex. So this is why she had her infarction. And just to prove it, because that's what she wanted, we did a follow-up angiogram, and you can see, voila, she has an LAD again. So this is a case of coronary dissection, easy to miss if you're not really looking for it. So this is not Minoka. Fibromuscular dysplasia is associated with coronary dissection, and you can see that nicely demonstrated in the renal arteries of this patient as well. All right, so we've done an angiogram, we've gone back and looked for it. We say maybe in this case it's not an embolism, it's not a dissection, it's definitely plain old Minoka. Consider additional imaging at this point in the cath lab, because intracoronary imaging with OCT and IVUS can find plaque rupture, plaque erosion, occult dissection, and thrombosis, and these may change your management. So should this be routine at this point? Well, in the ESC position paper, there's this statement that until there are additional research studies, you should use your clinical judgment, and you should consider plaque disruption and consider intracoronary imaging whenever you're not sure that it's vasospasm and you're not sure that it's myocarditis, which is going to be in a lot of patients, especially among those with evidence of athero on the coronary angiogram. And if you are doing it, you should do it at the time of the acute cardiac cath and let the patient know that there's some additional information you might get, but there is a small increase in risk as well. Here's a case where I think that intracoronary imaging really changed the way that we looked at the case. So here's a 44-year-old woman with anemia and menorrhagia. She had a hemoglobin of 7 2 weeks prior to the presentation. She had chest pain for 2 hours, but she's 44. She looked great. She had some subtle ST elevations on the inferior leads on the EKG. Her troponin was 0.09. Then she got a transfusion. She had more chest pain after the transfusion, and the next troponin was 3.25, so she's now taken to cardiac cath. What do you all think is the most likely diagnosis in this particular case? Could it be supply-demand mismatch from anemia? She's certainly anemic. A ruptured plaque, coronary artery spasm, or maybe this is spontaneous coronary artery dissection. So let's see what you all think before we get imaging this is going to be. Okay, so we have a group that is not sure, and I think that's very appropriate. That's why we're doing the test. We're not sure. But most of you, if we have a plurality, it's supply-demand mismatch from anemia. So here's the OCT of her LAD. And just to orient you, the round thing that's, I don't have the pointer, which is too bad, but the right thing, the thing around 2 o'clock is the catheter with all the circles. And then there's a shadow that's going down towards 7 o'clock, and that is the guide wire shadow. And then we have the intimal border, and then beyond that we have the rest of the vessel, so I'll let that play. Now we have a branch coming in, we have another branch coming in. Oop, I stopped it just a little too late, but at the top here, from about 11 o'clock until about 3 o'clock, we have a plaque that is a low attenuation plaque. And it has a thin cap. This is going to be a typical thin cap fibroatheroma, not expected in this patient. Oh, and there's a big thrombus. Not what we were expecting in a woman who was bleeding and very anemic. So I have some still frames here to make it a little bit clearer. So in the upper left, you can see the OCT catheter in its shadow. There's a linear artifact there that's highlighted in orange, but this serpiginous thing that's marked by the yellow arrow is an intimal disruption. And you can see in the next frame there's a lipid-rich plaque there, and then you can see in the next frames the thrombus coming in. And the MRI was also useful. You know, she had inferior ST elevation, and she in fact has an inferior infarction. But it just so happened that she had an LAD that wrapped all the way around the apex, and this is exactly where that LAD ended. So this is presumably embolism of that thrombus to the end of the LAD, causing this infarction. And had we tried to go by the EKG, we would have gotten the vessel wrong. So a lot of instructive things about this case. MRI tends to be very useful in these patients. It helps us to figure out if there is something that looks like an infarction with a vascular cause, if it looks like it's a non-ischemic cause, and the edema can even be helpful, even if we don't have late gadolinium enhancement. This is considered part of the routine workup in the ESC position paper, but I'm interested to know how the audience is doing now. So are you currently using CMR routinely in your patients with Minoka? And your choices are, yes, I use it in every patient, I use it sometimes but not routinely, or no, we're just really not using this at all. So please answer now. All right, so most of you are not using cardiac MRI. Let me try and convince you that you should be. The most convenient thing that we get when we get a cardiac MR is that we get a surprise and we had myocarditis. It looked clinically like an MI, but we send the patient for MRA and we get something that looks like a non-ischemic etiology. It's got these things that aren't centered in the subendocardium. The late enhancement may be beyond one coronary territory. We might see edema in multiple coronary territories, even if there's no late enhancement. And now, instead of going with dual antiplatelet therapy and a statin, as most of you said you would, we're going with none of those 3 drugs. So that is very useful, I think. And then a number of other patients will have a well-defined area of infarction, late enhancement that's centered in the subendocardium. So now we know that there's something vascular going on, but just from the MRI, we don't necessarily know which vascular problem we have. And so if you don't have intracoronary imaging and all you have here is the MRI, I would submit to you that you should use the dual antiplatelet therapy and statin because it might be a ruptured plaque or thrombosis or plaque erosion. But I would also add a calcium channel blocker here because vasospasm is fairly likely as well. If we have edema in one coronary territory, we would typically treat that as infarction. So that's dual antiplatelet therapy and a statin. If you get something that looks like Takotsubo with the typical wall motion pattern and the typical pattern of edema in all the mid-segments, well, that's Takotsubo. I'm not sure entirely how we treat it, but at least we know, we think, what we're dealing with. And if we have a diffuse edema, we might call it myocarditis. If we have a normal MRI, well, we're no worse off than where we started. But I would treat for the most likely causes, and that's plaque disruption and spasm, so that's, again, dual antiplatelet therapy and a calcium blocker. But it would be nice to know more, and so we need more research on this. The mechanistic studies to date have been informative, but they're small studies and they're single center, and we're cardiologists, not rheumatologists. This is not enough data for us. We need to define the prevalence and outcomes of specific etiologies. We need to understand the role of thrombosis. We need to figure out what the best diagnostic strategy is. I think it's this, but we haven't tested it and we don't know. And we need to select the best medications to use and what the target populations are for future studies. So we have had a very generous support from the American Heart Association, and we are embarking on the Women's Heart Attack Research Program. It is funded by the Go Red for Women Research Network, and we have the Sarah Ross Soter Center there. Judy Hockman is the director of the center, and I am the co-director. And the way this is designed is to have 3 synergistic research projects. There's the clinical imaging study, which is a multi-center diagnostic imaging study using 3-vessel OCT and MRI in women with Minoka. It's focused on women because Minoka is more common in women and also because that's the way the funding went. There's also a basic platelet study run by my colleague Jeffrey Berger in the back, and this is comprehensive assessment of thrombotic and platelet-mediated pathways in women with Minoka. We have a stress study. It will be interesting to understand if psychosocial stress is linked with Minoka, as it seems to be with Takotsubo syndrome. And so we have a randomized trial of a stress management intervention in women with MI, and the PI for that is Tanya Spruill. There are additional collaborative aims allowing us to understand the relationship between psychosocial stress and MINOCA and stress and platelet function. And you can see the participating sites here. So I have to sum up management of MINOCA in 3 slides, and here it goes. So MINOCA is a common problem. People think this is a zebra because it's not something that you may see every day and because we don't always understand what's causing it. But this is a common problem, and it behooves all of us to know how to treat it. MINOCA, there's more to think about, because we have to think about all these additional diagnoses. We have to think about doing additional testing. And it's kind of like talking to a woman instead of a man. 2 men say hi to each other, they mean hi. 2 women say hello to each other, and there's a whole lot of other stuff going on beneath the surface. And that's the way it is with the MINOCA patients. And as my colleague Nisa Goldberg has said about the red dresses, it's not enough to worry about heart disease in women, put on a red dress and think it's all going to be solved. And it's not enough to put a name on this as MINOCA and think you've got the diagnosis. You have to go beyond this to treat the right thing. So I think of these patients a lot like a box of chocolates. They might look the same on the outside, but you know they're different on the inside, and you care about which one you pick up. And I think that intracoronary imaging and MRI are going to be the right way to pick out which patients have which problem and treat them according to the underlying diagnosis. So thank you very much for your attention.
Okay, so we may have a chance for 1 or 2 questions, and I've got a few from the audience. I'll go ahead and invite Subhash to come on up while we discuss this. Informal poll, how many people have OCT in their cath lab that's available to use? Put your hands up real high. So I'm going to say that's maybe a quarter. And then my second question is, how many, I'm sure most of y'all have MRIs at your hospital, but the better question is, how many do you have MRIs that you feel confident doing cardiac studies on at your hospital, that you have radiologists or cardiac trained? So actually, I'd say a bit more have that. One of the questions, or actually 2 of the questions, deals with, if you do MRI, how late could you do it and still expect to see something? How time sensitive is that?
Very good question, and I don't think the answer is completely known. So the way that we usually think about it is that it's better to do it as early as possible, especially because not everybody is going to have late enhancement, and so you'd like to be able to catch myocardial edema, and edema is going to wane. It seems like the first 24 to 48 hours is the best time, but even a week or 2 out, you might see edema, and I think it is worth doing the MRI. Even if you get somebody later, let's say as a second opinion, I'll still go back and do it, because as I said, it's a no radiation test, and if it's normal, we're no worse off than where we started, but if we have something that points us in the direction of a particular diagnosis, that makes a difference for the patient. So ideally within the first week, and after that, I'd still try it.
Yeah, so I think a couple of days, if someone comes in on a Friday night, you could probably wait till Monday
Absolutely.
To get that test. And then the second question has to do, you mentioned intravascular imaging, IVUS, OCT, and I guess the question becomes, would you almost do that in all patients? Because obviously you're in the cath lab before you're going to have a chance to get an MRI to prove that it might be something that you could discover there. So how often would you do it at your institution, or when would you recommend that this be done?
Well, at this point, we're enrolling in our study, so we're doing IVUS and OCT routinely. But to be fair, I think that it's not really known if this is something that's going to be helpful, and we do need research studies to prove it. I would say in the interim, I think it's useful information, and I would recommend it. I would particularly recommend it in STEMI patients. So in the following session, we're going to talk about a STEMI case of MINOCA, and you should know that having ST elevation in the context of MINOCA, that's only 1% of MI cases, but those people are at very high risk of dying relative to the rest of MINOCA. ST elevation is an even more important predictor of death in MINOCA than it is in regular MI. So I feel even more concerned about those patients and even more inclined to try and make a diagnosis.
Okay, I'm sorry, did we have a question out here? Okay, then we'll have a chance at the end. Thank you very much, Dr. Reynolds. We'll have a chance at the end.